So this one is actually a comparative study of Lisocabtagene Maraleucel, which is from the pilot study, the prospective clinical trial in patients who were with refractory or relapsed large B-cell lymphoma for whom transplant was not intended, and comparing that cohort with a conventional second-line chemotherapy regimens offered to similar patients in the real-world setting. So we know that historically patients with relapsed or refractory large B-cell lymphoma who are not intended for transplant have had poor outcomes and limited treatment options. In pilot, Lisocabtagene Maraleucel demonstrated efficacy in such patients. So in this study, the primary objective was to assess the comparative effectiveness of liso-cel in pilot with conventional second-line chemotherapy regimens in the real-world setting. What we did is, the pilot cohort in this analysis included all the patients who received Lisocabtagene Maraleucel, and the real-world cohort were derived from multiple data sources collected retrospectively, and considering the intention to receive transplant was not documented in the real-world data, the external control cohorts were derived based on pre-specified eligibility criteria in pilot. We performed endpoint analysis using inverse probability of treatment weighing or IPTW method. And, we started with an initial comparative cohort, which included the broader population of patients who had relapsed refractory large B-cell lymphoma after one prior systemic therapy. And then we looked at patients who would have met pilot eligibility criteria. And these were selected as the qualifying comparator cohort. And then finally, we went down to an analytic comparator cohort, which was constructed by balancing the qualifying comparative cohort and pilot population using this IPTW, which uses weighting methods to sort of compare the two groups, understanding that this is not a randomized study. So we try to overcome that by this weighting method. So in terms of the follow-up, the median follow-up time was 12.3 months for pilot and about 9 months for the real-world cohort. And the baseline demographics and patient characteristics were very similar in the pilot cohort compared to the real-world cohort. And then most patients in the real-world cohort received rituximab plus R-CHOP chemotherapy as first line, and the most common conventional second-line chemotherapy in the real-world cohort was the RICE chemotherapy, followed by bendamustine-based chemotherapy, and then gemcitabine oxaliplatin-based chemotherapy. So those were there were other regimens which are used, but the numbers were very small. And the overall response rate and complete response rates was significantly higher in the pilot cohort versus the real-world cohort, with both p-values being highly significant for that. And the median duration of response was also much more favorable for the pilot cohort at 12.1 months versus the 4.3 months in the real-world cohort. And that was, again, a very statistically significant point. And then, when we look at the survival endpoints, such as event-free survival, progression-free survival, overall survival, they all demonstrated statistically significant and clinically meaningful differences in favor of Lisocabtagene Maraleucel in the pilot cohort versus the conventional chemotherapy cohort in the real-world population. The event-free survival was 7 months with Lisocabtagene Maraleucel compared to 2.8 months with the conventional chemo, and the median overall survival was not reached for the pilot cohort, and it was 12.6 months for the real-world cohort. So again, very, very significantly beneficial, efficacious regimen with Lisocabtagene Maraleucel compared to conventional chemotherapy. We also performed sensitivity analysis, excluding patients who received intention to transplant regimens. In this sensitivity analysis, efficacy outcomes significantly favored treatment with Lisocabtagene Maraleucel in pilot cohort versus conventional chemotherapy regimen in the real-world cohort. And the median, event-free survival was 7.2 months in Lisocabtagene versus 2.8 months in the conventional chemo. So to summarize, in patients with relapsed refractory large B-cell lymphoma or not intended for transplant, efficacy outcomes significantly favored Lisocabtagene, Maraleucel in pilot versus conventional second-line chemotherapy regimens in the real-world setting. These statistically significant differences in favor of liso-cel or Lisocabtagene Maraleucel were noted in adjusted overall response rate, complete response rate, duration of response, event-free survival, progression-free survival, and overall survival. And therefore, these results support the use of Lisocabtagene Maraleucel as an effective second-line therapy for patients with relapsed refractory large cell lymphoma who are not intended for transplant.